Hello, everyone. I see that we have 8 people on. For those that show up early, we're going to give everyone else another few minutes before we get started. But thank you so much for joining us. So if you just hopped on, we're getting ready to start our live. We're just going to wait a few more minutes for people to join us. Thank you for joining us. All right. Well, because we're timely, folks, I would like to welcome you. Hello, my name is Susanna Craig. I'm with Pandia Health as the Chief Operating Officer. I'm so glad that you're joining us for today's event about perimenopause and the different journeys and shared support that we should all have. As we know, perimenopause and menopause are universal life transitions, but as Dr. Yen and Dr. Edwards remind us, they're also unique journeys. Each woman's experience is shaped by the mix of biology, culture, access to care, and lived experiences. Our goal today is to bring you that complexity to more clarity and to talk about it openly about what's normal, what's not, and how you could feel informed no matter where you are in your journey. So today we're joined by two exceptional physicians who have devoted their work to improving women's health care. First, I'd like to introduce you to Dr. Sophia Yen, CEO of Pandia Health, a menopause certified practitioner and a passionate advocate of personalized evidence-based care through telemedicine, asynchronous to be precise. Dr. Yen will discuss how we treat symptoms and how to identify signs of peri and menopause and the consequences, most importantly, if you leave them untreated. And then excited to have and listen to Dr. Colette Edwards, founder and chief medical officer of Pausitive Health and one of WOW's top 50 leaders in menopause for 2025. Dr. Edwards will present factors like race, mindset, and income, and access to menopause-trained clinicians and how they can influence patients' experiences. So that's the two awesome doctors that we have here talking. But what we'd like to do now is start first with Dr. Sophia Yen. If you could please introduce yourself, tell us a little bit more about how we could spot those signs and symptoms about perimenopause. And then right after that, we will hear from Dr. Colette, Dr. Edwards Colette. So take it away.
So hi, everyone, CEO and co-founder of Pandia Health. As Susanna mentioned, we're the only women-founded, women-led, the only doctor-founded, doctor-led, asynchronous telemedicine and pharmacy in birth control and peri/menopause. I grew up in the Bay Area in California, went off to MIT, froze my butt off, said I'd never do the East Coast again because it's too cold, and then came back to UCSF, Children's Oakland, back to UCSF to specialize in adolescence, and then a master's in public health at Berkeley to get all the degrees in the Bay Area, specializing in maternal child health, focusing on obesity. Finished off at Stanford, where I'm a clinical associate professor in the Department of Pediatrics and the Division of Adolescent Medicine, and then co-founded Pandia Health to make sure no one runs out of birth control on our watch and that women get expert menopause care by 100% physicians wherever you have internet and a mailbox. I'm going to share my slides now. I have lots of screens open. Yay. Okay, cool. It's queued up, ready to go. And I'm going to do this view so you guys can see. So know, if you don't already know, that there are barriers to peri/menopause care. On average, if you call your doctor's office, it's going to be 3 to 6 months to see a physician. At Pandia Health, we take care of our menopause patients within 3 to 5 business days. Know that 90% of women with menopause symptoms go undiagnosed. And the example I give is I'm a doctor, I'm a total doctor snob, and I made sure I picked the best doctor. What residency did you go to? What medical school did you go to? And she's great on other things. But I showed up as a 52-year-old woman on constant birth control pills to smooth out the chaos of perimenopause. So I had no hot flashes, no night sweats, but my waist disappeared and my cholesterol shot up. And she's like, oh, that's old age. Go see the nutritionist, go get more exercise. And in my head, I'm like, I'm an obesity expert and people wait 6 months to see me. Nothing has changed from last year to this year. But I was like, okay, I guess that's old age. And then I became a Menopause Society certified practitioner, where you read up on the latest and greatest and learn that when you take away estrogen, the fat deposits centrally at your waist, so your skirts and your pants don't fit, and then your cholesterol shoots up, your triglycerides, your LDL. And so I switched from continuous birth control to the bioidentical estrogen and progesterone, FDA approved standard treatment your doctor can prescribe. And then my waist came back, and then my cholesterol got better, but I also went on statins. So doctors can get gaslit too, is what I'm saying there. And then on the bottom left, you'll see that 69% of OB-GYN residencies that were surveyed in 2023 had no menopause curriculum. And who knows what your internal medicine or family medicine doctor has. The lack of experts leads to poor outcomes. There's only about 3,000, maybe 5,000 Menopause Society certified practitioners in all of North America for the 1 million women entering menopause each year. And if everybody went on HRT, 60% of fractures could be avoided. Without HRT, you have a 50% increased risk of heart disease. You have a 24% increased risk of colon cancer and a 21% increased risk of diabetes. It's important that people understand that we have many seasons of hormonal changes. So puberty, and then your fertility years, and then perimenopause, we call the zone of chaos. And then when your ovaries are like, thank you for your service, I'm out of here, I'm retiring, I'm not giving you any more estrogen or progesterone, then it goes down and the levels are very, very low. Definitions, very important for you all to know. You don't need to know final menstrual period, but menopause is technically that last period. And for those of you who haven't entered it or are soon approaching it, what is this chaos limbo of perimenopause is the 5 to 7, 10 years that leads into menopause, where your periods are irregular. And we only know you have menopause when it's been 12 months and you haven't had a period. So for those of us that had to go through it, it was really frustrating because you get a period and be like, yay, maybe menopause. And then 3 months later, bleh, and you're like, oh, got to restart the clock. Then you'd be like, come on. And then 6 months, bleh, and you're like, oh, my God, it's like, God, I have to keep going. For others, they just had it and they're like, nothing for 12 months, lucky you. The median age of menopause / your final menstrual period is 52 and a half. I know there's a lot of for-profit companies trying to scare people that, oh, you need to start looking at perimenopause in your early 30s, late 30s, early 40s. I wouldn't worry about it until perimenopause is like 5 years before that. So like 47, maybe 42, but definitely not in your 30s or late 30s. And certainly it's possible, but that's like 1 in a million. Greater than 40% of our lives will be spent after menopause. So it is not the end. It is just another phase of our life. And 60% of us will survive until 80. And I want to live to 100, 120 in good health. Perimenopause, by definition, is irregular periods. So if you're getting periods every 28 days and you have these other symptoms that are similar to menopause, it is not menopause if you have regular periods. If you have irregular periods, then yes, it could be perimenopause. And then postmenopause, technically, we all lay people call it menopause, but it's technically postmenopause, which is that last period, and all the time after that is postmenopause. Symptoms of menopause, they're the classic symptoms: changes in your menstrual cycle. If you don't have your cycle whack, that is not perimenopause. If your periods have gone away, then that is menopause for a year at least. Vasomotor symptoms, hot flashes, night sweats. Vulvovaginal symptoms, painful sandpaper vagina, it rips, it tears, it hurts. Painful sex dyspareunia, sleep disturbances, waking up in the middle of the night, can't go back to sleep. Psychological symptoms, depression, anxiety, moodiness, certainly those can happen separately. Other cognitive symptoms such as memory, concentration. For those of you who've gone through pregnancy brain, it is worse than pregnancy brain. Joint pain, dry eyes, change in weight distribution. There is no one universal menopause syndrome, but certainly it's inherited. So whatever your grandma, your mom, your auntie, your father's side of the family, you should check that all out. These are just some of the 70 to 100 different symptoms. It's to make you know you are not alone. You are not crazy. It is not all in your head. The ones I love to point out is if you haven't plucked a hair from your chin where you've never had hair before, or once you've done that, you're part of the menopause club. I haven't had zits in 20, 30 years, and I got a giant zit full of pus, causes me pain, causes me scarring, all sorts of like demoralizing to my ego and self-concept. Want to go over heavy menstrual bleeding again, to know that in perimenopause, your hormones are whack. And if you have too much estrogen, a lot of blood builds up and you can have random heavy bleeding. And so heavy period is defined as heavy flow for 3+ days. Prolonged bleeding is 8+ days. 20.7% of women, 1 in 5, experience heavy menstrual bleeding. 5% have 3 or more episodes of this. 24% of women have prolonged many days of bleeding, which can lead to anemia, which can lead to iron deficiency for sure, which can lead to being tired, cold, heart beating fast, looking pale. Please see a doctor. 4.6% have 3+ more episodes. And I just want to give, 2 stories because they stick in people's head. An acquaintance of mine before we went into menopause told me she couldn't visit friends' houses for a month because she was afraid if she sat down, she could destroy furniture. If she stood up, she could destroy furniture. And so did not visit friends for months before I went into menopause. Otherwise, I would have been like, anything that lasts more than a week, please see your doctor. We have drugs, we have science. Hashtag stop sucking it up. You don't get a gold medal for seeing how long you can fatigue. In the past 2 weeks, we asked people, have you felt tired? 27% felt tired. 24% felt worn out. Other reasons for fatigue, definitely iron deficiency. And only 6% of women that have these heavy menstrual bleeds get care. Well, I want that to be 90%. And then palpitations, 1 out of 2 of us will have sudden racing, skipping, pounding, heartbeat. And while often benign, which means no big deal, meaning not going to kill you, not something a doctor needs to work up or look into, these sensations can feel alarming and are directly linked to the hormonal shifts. And so if you're having them more than once, if you're having them faster and faster, frequently, more severe, or if you have any chest pain, go see a doctor. But if it's just once, then it's okay. But if there's some crushing chest pain, like a heart attack, please 911 if you have to. Want to reemphasize that perimenopause is chaos. And on the right here, I like this because it shows you have too much estrogen, you get tender breasts, you get weight gain, and more importantly, you get extra estrogen with whack blood. The progesterone dropping causes irregular bleeding and sleep changes, and then the estrogen drop, but the fluctuations causes hot flashes and mood swings. And so this is, if you want to get really technical, why the periods get all irregular in perimenopause is the popping of the eggs gets whack and you get 2 of them stacked on top of each other. Then you don't get bleed until a while. And then the estrogen piles up with more blood. And so on the left is the chaos. On the right is what you can achieve with the birth control pill or vaginal ring during perimenopause. And that is really the best treatment. And then lastly, if you want a talk on hashtag periods optional, this is my gift to the world. Anyone who's bleeding every month, but particularly as you hit perimenopause, you may want to make hashtag periods optional. Go to pandiahealth.com/periods optional, and you can see my TEDx talk on the bottom. And I hand it off to Dr. Edwards.
Wow, thank you so much, Dr. Yen, for that informative presentation. I know for me personally, periods optional when I was in college would have helped me a lot because there's such a huge amount of expense that we spend, right, on menstrual products on top of suffering every month with that pain. But anyway, leading on, Dr. Edwards, thank you so much. I'll leave it up to you. I'll let you go ahead and take the stage.
Okay, thanks so much, and thanks for inviting me to participate. Happy to be here. I'll just tell you a few quick things about me. As was stated before, founder and chief medical officer of Positive Health, and I started down this journey because I had an admin who was going through perimenopause at the time and had let's just say a less than optimal experience with her GYN and her PCP at the time. And that got me wondering about what was available for women to learn about this time of life, what kind of experiences they were having. And to make a long story short, what I found was that people felt like things were coming out of the blue, that they were unprepared, that there wasn't for when you're having a baby, there's the what to expect. There wasn't one of those books for women who were going through the menopause journey. And so I felt that there was a need that needed to be filled, given that every single woman will go through menopause if she lives long enough. And so that's how I got started down this pathway. In addition to my medical background, I also have training in health and wellness coaching and health disparities through a program with the NIH. And my topic for today is really looking at what is a universal life transition, but how the journeys can be different. As was stated previously, each person's journey is unique, but there are certain factors that can impact the type of experience you have. So you have some people who sail right through and it's a non-incident. You have other people at the other extreme where things are so severe that they either have to cut back their hours or step back from promotions or leave the workplace altogether. So there are several factors that can contribute to the type of experience that a person has. And they include your menstrual history, your pregnancy, your family history, the age of onset of menopause. It can even be where you are located in the country. So for example, research has observed that women who live in the South tend to have more severe symptoms. The research has not told us why that would be, but that is an observation that has been made. Your education level and income, whether or not you have access to menopause trained clinicians, whether you have access to insurance coverage, whether you have pre-existing conditions, and then your mindset and your culture. And so some examples for some of these. So with regard to family history, it is not uncommon that the experience that you have may be similar to what your mother experienced. It may not be, but that is not uncommon. It is the case that issues that may arise during pregnancy or after delivery with regard to your pelvic floor, if they are not addressed, or even if they are addressed, they may pop up again later when you're going through menopause because you're going through another hormonal transition. If you don't have access to menopause trained clinicians, you can find yourself in a situation where you are going from pillar to post and going round in circles and being sent from one specialist to another. So sent to the cardiologist because of palpitations, sent to the gastroenterologist because of GI symptoms, sent to the neurologist because of brain fog, etc. And so if no one is really thinking what could be a potential explanation that would pull all these symptoms together, you can see how you could spend a lot of time going a lot of places and spending a lot of money out of pocket and still not getting an answer, and potentially even being told that it is all just stress or in your head. In addition to these factors, your race and ethnicity can also impact the type and duration of the symptoms that you have during the 3 stages of the journey. So, for example, on average, women of color tend to have an earlier age of onset of menopause. There are certain groups of women who tend to have more severe symptoms of a certain type. So, for example, Black women tend to have more severe hot flashes, and they tend to last over a longer period of time. And besides the inconvenience that that causes, it also has implications from the standpoint that if those hot flashes go untreated, then it increases the risk of heart disease and dementia. And to go into just a little bit more detail, we're all 99% the same genetically. But for the reasons that I had stated before, certain groups tend to have certain symptoms more than other groups potentially, and health risks that may be greater or lower than other groups. And even if you look within a given race, when you look from an ethnicity perspective, you may see differences as well. And that would tie into a person's culture, a person's mindset, how this stage of life is viewed. There are societies, there are cultures where women, as they get older, are viewed as women of wisdom, as being sexier, as being more experienced, which is certainly not the typical messaging that you get in this country. So that can make a difference. And when you look at the research, it is often the case that if you have a more positive attitude about going through the transition, your symptoms tend to be less severe. So just as an example, in white women, the average age of menopause onset is 51. For women of color, it tends to be at a younger age. For white women, the perimenopausal stage tends to be about 4 years. For Black women, it tends to be 10 years or more. And when you look at all women together, it is around 7.5 years. And 65% of white women will experience hot flashes and night sweats, just as an example, and have different issues with regard to issues with sleep, just as an example. I have covered several of the issues noted with Black women. Another place where you may see a difference is they tend to have more depressive symptoms than other groups, and also tend to report greater stress. Latinas tend to have more issues with GI symptoms, with heart symptoms, greater issues potentially with genitourinary symptoms, so bladder issues or issues with vaginal dryness that can lead to problems with sex, as well as sleep issues. Native women may experience what would be considered perimenopausal symptoms at an earlier age than average, although that may not signal that they're actually going into early or premature menopause. And Asian women, when you look at the literature, they are reported to have fewer symptoms and an easier time, which indeed could be the case, but it could also be the case, like with other situations, that what gets reported is what gets studied and what gets said to a doctor or a researcher. So if certain things are not brought up, then when you look at the entire population and start doing comparisons, things may appear to be different than they truly are. And so it's a question in my mind as to whether or not it is truly the case. Although they may have an easier time, it is definitely not the scenario that everyone's sailing right through. Native Hawaiian and Pacific Islander women tend to have greater health risks to start off with. The menopause journey is a time due to the change in the estrogen level to increase your risk of conditions like heart disease or osteoporosis. And so if you are already starting off with a greater likelihood of having, for example, high cholesterol, that gets further exacerbated during the menopause transition. And then it becomes very important, as it is for everyone, to really focus, take me time, focus on preventive care, a healthy lifestyle, and getting your symptoms treated and not suffering for no reason. It's just not necessary. There are way too many options in today's world to sit and suffer in silence. And I will stop right now, and then I guess we can go into questions.
Oh, thank you for that. But, I would like to see the following slide about the services that Positive Health offers. I think that's important because education is everything, right?
Yes, it is. So Positive Health, which is the company that I founded, the goal is to have one place where everyone can go, no matter their stage of the menopause journey, a one-stop destination. A big area of focus is education, and some of that entails 14 content tracks, but also a webinar and podcast series, as well as a newsletter, access to menopause-trained clinicians like Pandia Health clinicians, food as medicine. So, for example, a diet assessment, which comes with a score that you can track, recommendations based on your goals, a recipe library, very much trying to look at things holistically. And so music as medicine with playlists that have been scientifically proven to help with things like mood and sleep. Many women have joint and muscle aches during the menopause journey. So you have access to a physical therapist, virtual consultations, and you can see a person for aches and pains, or for those who have pelvic floor issues like leaking. You would have access to that, as well as access to a library to help with both issues. Many people experience stress. People may have anxiety, depression when they've never had it before, or if they have, it can trigger an episode. And so there is digital cognitive behavioral therapy to address that, and as well as a community. And then the big news is that in 2026, we will have a mobile app available with additional features that we're very excited about. So thanks for the opportunity to just tell people a little bit about Positive Health.
Oh, you're so welcome. I mean, this is something, of course, that we're so passionate about, and that is to make sure that not only do you get the treatment, but also the other components of a good diet, understanding what you're going through. So to get all that information really completes the whole cycle, I think that all of us are interested in. So thank you so much, Dr. Yen and Dr. Edwards, for these great presentations. Now, let's dive into some things that a lot of us have been experiencing, and also some questions from our viewers. But I want to dig into this a little bit more. Being a Latina, right? Yeah, I concur that we do have this mentality of just sucking it up and just dealing with it. It's just this hot flash. I could deal with it, but what we forget is that we may be dealing with it, but the long-term effect can be more, right? So can you give some input, Dr. Yen and Dr. Edwards, about why we should not just knuckle it up and just suck it up?
So hot flashes are not just a benign scenario. They can, if left untreated, increase the risk of heart disease, can increase the risk of dementia. And just by virtue of being menopausal, once you're on the other side of that day where your periods stop, and during this process, your estrogen levels are falling. So you have an increased risk of conditions just from that alone, such as hypertension, heart disease, high cholesterol, osteoporosis, anxiety, depression. And therefore, if you already have the hormonal change causing the increased risk of heart disease, and then on top of that, you have untreated hot flashes, now you've got a double layer of increased risk. And so things that you don't take care of now can come back to haunt you later. Just like the importance of strength training, which helps prevent osteopenia or thinning of the bones, or osteoporosis, which increases the risk of fracture. There is a condition called musculoskeletal syndrome of menopause that increases the risk of osteoporosis as well. And so you really don't want to be a hypochondriac, and you don't want to call the doctor about every little thing, but these are serious symptoms that need to be taken seriously, and they need to be addressed. And I can't emphasize enough, there are many options out there. There is no reason for a person to suffer in silence.
Yeah, thank you.
Yeah.
I think that the key thing is that you may think that, oh, I don't want to take the time. It's going to be a lot of money. But now, we have companies like Pandia Health, if I must do a shameless plug, and like Pausitive Health that enable us to get really good care at, a inexpensive price, right? Whereas, I know for me, that was one of my thoughts. And I did go to the doctor, and I went to the doctor with education from my company. And even then, it was like, maybe you want to see a neurologist. And I was like, oh, okay. $2,000 later, right? I didn't need it, but I was like, well, if the doctor's recommending it, had I talked a little bit more with my Pandia Health physician, I would have realized that I did not have the symptoms for that in order to go and spend $2,000 later. Dr. Yen, would you like to add anything else to this? Oh, you're on mute. You're still on mute.
Sorry. Yeah, I must have coughed or sneezed and wanted to mute that. I'm going to share some slides that I prepared for the FDA approved reasons for HRT.
Okay.
So
thank you for responding to the questions there. I know Laura was like, I'm a Latina, I missed something.
You blinked and it flew by, and this is recorded, right? So we'll have it up on YouTube later. These are the FDA approved reasons for HRT, MHT, HT, though as we discussed, it has many benefits. The main one is for preventing cardiac death. The number one cause of death in a breast cancer survivor, cardiac disease. The number one killer of women right now, cardiac disease. But unfortunately, that is not one of the FDA-approved reasons for HRT. But if we treat you systemically for one of these reasons, then that might be a side benefit. I separated the genitourinary syndrome of menopause because that technically can be treated with just vaginal estrogen. And know that vaginal estrogen can be used by anybody, even if you have breast cancer, because it is not absorbed systemically, that it would go to your breast or your bone or your blood or your brain, any of that. It's just local. But it does treat urinary frequency, where you feel like you need to pee, but there isn't any pee. Frequency, urgency, it prevents urinary tract infections. If you talk to a urogynecologist, who's a urologist that specializes just in women's urinary tract, they believe that everyone 52 and above should just throw down some vaginal estrogen to prevent urinary tract infections and urosepsis, which is when the urinary tract infection goes into your blood and the bacteria everywhere and can kill you. And the example I give there is I had a family member, 70 years old, started to get recurrent urinary tract infections. And I was like, oh, that's interesting. Got urosepsis. I was like, usually urinary tract infections occur in a 20-year-old who's having sex and doesn't know to pee after sex. And so I was like, eh? And she's like, no. And then this is before I learned about menopause and had become a Menopause Society certified practitioner. And then I was like, oh, let's try some estrogen. And with that, has not had any more UTIs. I had a friend whose mom is in an older person's home and was having recurrent urinary tract infections. And I was like, hey, vaginal estrogen. And he's like, okay, let me talk to her provider. Spoke to her provider, no more UTIs. And now everyone at the older folks' home, thanks to me educating him educating the provider, a lot less urinary tract infection. So if you know any people, please make sure they know. And then vaginal dryness, as I talked about, sandpaper, painful sex. Again, all of that can be treated with vaginal estrogen, but if you do systemic estrogen, it hits this 50% of the time. The other three things that Pandia Health can prescribe for, because we have to stick to these, because if we get sued, we lose the company and the whole thing goes down. So we cannot go off label, but a doctor you see in person can go off label, but we cannot. Moderate to severe hot flashes, moderate to severe night sweats. And then the last one I say, as a person of color, we never have a leg up in medicine, but in this one, 70% of us are lactose intolerant and we're pretty bad at getting calcium. So we instantly qualify for at risk for osteoporosis. So if you do not get enough calcium, you're at risk for osteoporosis. If you have a family history of osteoporosis, your mom, your auntie, your sister, then that's definitely a risk for osteoporosis, and we could prescribe for that. I did want to hit the myths about HRT, past concerns. HRT's reputation suffered due to a flawed study, the Women's Health Initiative, which had a press conference even before other doctors reviewed it and made sure everything was right. In 2002, never before heard of. There were three major flaws in this study. One, they used Premarin, which is pregnant mare urine. So a whole bunch of pregnant horses gathered up their urine, took the estrogen and gave it to women. And then they used synthetic progesterone, medroxyprogesterone acetate. We now use bioidentical estrogen, bioidentical micronized progesterone, though we don't even say that anymore. We just say progesterone 100 milligrams, progesterone 200 milligrams, but that is bioidentical micronized. And because a lot of people confuse bioidentical with compounded. We do not recommend compounded. The American College of Obstetrics and Gynecology and the Menopause Society, when you have all these FDA-approved, FDA-tested things available. And then last flaw on that study, average age was 63. We now recommend that you get on estrogen within 10 years of your last period, and it's best during that time. And as I mentioned before, the average age of menopause is 52, plus 10, 62. So the average age in the study was 63. And so to explain to you the biological mechanism, when you take away estrogen, your arteries get hard. They no longer dilate. They fill up with triglyceride and LDL. And then you throw estrogen, which causes blood clots on top of that. You're going to get bad stuff. So that's why as soon as you take the estrogen away and all this badness, put it right back to prevent the hardness, to prevent the filling up with LDL and triglyceride. And then when they did study just the women that had estrogen, even in this flawed study, there was a group that didn't get progesterone, the synthetic progestin, medroxyprogesterone acetate. That group of women, because they didn't have uteruses, they didn't give them progesterone because the progesterone is to balance estrogen stimulating your uterus, growing its lining. The estrogen only had 37% decreased breast cancer, had 44% decreased breast cancer death if they got breast cancer. So it is no longer the estrogen and HRT that we believe is causing breast cancer, increased risk of breast cancer beyond baseline. It is, we believe, the synthetic progesterone. And so the truth about HRT is the gold standard for menopause treatment. People try to sell you supplements and stuff. Ask them, has it been in a randomized clinical trial where 50 people got the supplement, 50 people got estrogen, and did the supplement beat estrogen? Because all the research, estrogen beats the supplement. If you can't take estrogen because you have a blood clotting disorder, or you have a cancer that's estrogen sensitive, then yes, please check out other alternatives. But know that there are also other FDA approved and tested treatments for the symptoms of menopause. Know that many providers are not up to date on the current research, and the key is to see a menopause specialist, or at least somebody who's up to date on the latest and greatest, or a Menopause Society certified Practitioner. And so to test your doctor, if they're up on the latest and greatest, say, hey, what's the latest in menopause treatment? Would you say the lowest amount of estrogen for the shortest amount of time? And if they say yes, they just failed. That is no longer the standard of treatment. It is now shared decision making. And I personally believe that you don't start somebody at 0.025 when if I took out your ovaries today and you were under 50, I'd start you on 0.1. So why would I start you on 0.025 if you're 50 plus 1 day? I should start you on something closer to that. And at Pandia Health, we start on 0.05 and we move our way up. Know that menopause symptoms are significantly relieved by estrogen compared to any supplement, protects against osteoporosis, heart disease, and possibly dementia. And certainly if you have a personal history of breast cancer, that is a one-on-one discussion situation. Pandia Health will not touch you if you have a personal, I had breast cancer and I'm a survivor, except we will do vaginal estrogen because as we stated, the vaginal estrogen does not absorb systemically. We're totally fine with that. The bioidentical comes in patches, creams, gels, and then the local vaginal estrogen and the progesterone. And again, best within 10 years. So that's what
Thank you. Well, thank you so much for all of that. Definitely going to have to re-listen. I'm going to go ahead and post some questions that our attendees posted when they signed up. And I think the first one you kind of answered, but this is a question I had because I white knuckled it, right? So is it too late to get menopause hormone treatment if I'm 58 to 59 years of age?
So if your last period was 47, then I would say no. But generally, physicians are totally fine doing HRT within 10 years of your last menstrual period or under the age of 60. Everything is, on a one-to-one basis, and each person is different. But that is the general, rule of thumb is within 10 years. And certainly, I'm sure there's a curve that gets worse, right? The more your arteries get clogged up, the worse it is. And once you're above 60, if you have no hypertension, no cholesterol, you have a clear CT cardiac scan, then shared decision-making could be done. Again, not with Pandia Health because we can't take that risk, but with an in-person doctor, they might be willing to take that risk with you.
Absolutely. And you can always use one of our pharmacy partners, Pandia Pharmacy, to deliver that medication once you see your primary or your OBGYN. Dr. Edwards, would you like to add anything to the question?
I don't think so, not at this time.
Okay, great. So I guess second question from patients is, what is the average age of perimenopause? And is there any way to get ahead of the symptoms to try to avoid them?
So I think
I like this person. Like, how do I beat the system?
Yes. Why suffer? Why suck it up? So I think this is a lot to do with hashtag periods optional. If you watch my talk, I had the epiphany getting pregnant with my first child that those of us with uteri, the only reason we bleed every month is we build that lining and we're like, embryo? Oh, no embryo, bleed. And then we build it up and then we bleed and we build and we bleed. And so the only reason we bleed is because we didn't catch an embryo that month. So if you're not trying to catch an embryo, and most of us, we crank out 2 kids and we're done. So why are we bleeding every single month from after that second or last child until 50, 52? So that whole time you could do hashtag periods optional. But a lot of women, after they have kids, they don't have as much sex. They got a tubal ligation. Their husband got a vasectomy, whatever. They're like, I don't need birth control, but you can use the pill, patch, ring, the pill or the ring or the IUD or the implant to make hashtag periods optional. And for perimenopause, the best treatment is to take over and smooth that out with estrogen and progesterone stable rather than up and down and all the consequences of that as you enter into menopause. The analogy I give is like running out of gas. You can either put like random, or like me, I'm a control freak, everything smooth. And then when I hit 52, 53, be like, am I there yet? Okay, let's switch over to HRT. Once I have the other symptoms, my body outed itself by the cholesterol shooting up in 1 year. That is a drastic, that's a hello, I'm here. And then the waist disappearing. Those were my two signals.
So the waist, yeah, but you were skipping your period all throughout. So those are the symptoms, right?
Yeah, I couldn't tell on the period situation, but the symptoms was the cholesterol and the waist gone away. So to avoid perimenopause, if you're on periods optional, you won't get the hot flashes, you won't get the night sweats, you won't have a lot of the symptoms. You'll have some of the other ones. I think I noticed brain fog and others, but that might have also been when I came off the constant birth control. Then I hit brain fog, and brain fog is real.
It's real. Okay. Well, thank you so much, Dr. Yen. So, Dr. Edwards, what impact can COVID have on menopause?
Well, and I'm glad you brought this up, because although we may not hear very much about COVID anymore, it is still very much alive and well. In fact, there is a new variant out now, which is called the Frankenstein variant, which doesn't sound like anything that I would want to have.
No.
And so the way that you're going to end up getting long COVID is to get COVID in the first place, and women are much more likely to get long COVID. Women who are in the perimenopausal phase, if they do get COVID, they tend to have less severe symptoms than those who are postmenopausal. And postmenopausal women are more likely to have severe symptoms more comparable to what a man would have. And COVID can also impact your period. So if you're in that perimenopausal stage and you're still having periods, it can totally disrupt things. And for some people, it means heavier bleeding. For some people, it may mean more irregularity. For other people, it may be a lighter period, or someone who is basically bleeding all month in dribs and drabs. So it definitely can have an impact that is not your imagination.
Okay. Well, we have one of the first questions that I'd like to bring up as well, and I'm showing it here. Jennifer says, "I'm still trying to get pregnant while in perimenopause. Is there a recommended protocol to follow to optimize my health?"
Yeah, so I would simply, talk to a fertility specialist, because if you're in perimenopause, by definition, your eggs are not coming out regularly or normally. And so you definitely need to speak to a fertility specialist. I did put in the comments that, they may put you on a birth control pill to normalize your hormones and kickstart and know exactly when you need to go and get pregnant, or that people who have polycystic ovarian syndrome, physicians that are fertility experts actually put them on the birth control pill to stabilize their hormones. And when they come off, that's the most normal they're ever going to be. So after the sloughing, that is your best, most fertile time. And they'll sometimes prime with extra egg pushing during that time as well. So don't be shocked if they put you on the birth control pill to normalize things, to kickstart off your fertility. And then just in general, anyone trying to get pregnant, definitely take prenatal vites to make sure that your body is up on all the possible nutrition, so that when you get pregnant, it's all ready to go.
Wonderful. Thank you. We're getting close to, I think we passed the time, but one last question. If someone can easily see a menopause trained clinician, what questions should they ask? What information should they have on hand when they get ready to meet with that physician?
I would say on our platform, we like you to be up to date on your healthcare maintenance. So a mammogram, if you're 45 and over within the past 2 years, and make sure your colonoscopy is there, though they've shown that HRT actually decreases your risk of colon cancer. So we don't necessarily need to check anything there. Breast cancer, there's always a concern, but as we've discussed, the estrogen doesn't increase your risk of breast cancer above baseline. It but the synthetic progesterone does. And actually, I didn't put out that bioidentical progesterone has not been shown yet in any studies to increase your risk of breast cancer above baseline. So we may not even need to require that in the future as we get more research, but currently we definitely ask to make sure.
Amazing, thank you. And one last question from one of our viewers. I'm 64. What options do I have for hot flashes and night sweats?
So at 64, I presume you're 10 years out. If you have a clean cardiac bill of health, it could be shared decision making with a physician, but know that there are non-hormonal treatments for hot flashes and night sweats. So paroxetine is usually an antidepressant because it affects the neurological symptoms. It also works for hot flashes. And so there's this specific one approved for menopause, but costs a ton of money, which is 7 milligrams or 7.5 or 8.5, some whack number. But there's a basic generic one for 10. So we just do the 10 milligram to save you money. Or there's Veoza, which is a selective estrogen receptor modulator. And that is, or actually a Kindi, a neurokindi. It's a new neuronal thing that causes the hot flashes situation. And there's that option. And then there's other ones that can be used as well. So you have those options.
Great. Thank you so much for that answer. And then one last one, I promise. So Frances is asking that her uterus was removed at 32. She's 90 now, and her doctor told her to stop taking, hormones because it caused blood clots.
Yes. So
that's a very.
I would say you're 90 years old. It's a shared decision-making situation. It's the risks versus the benefits. It's the doctors willing to take on that liability. But I would definitely recommend transdermal estrogen so that you avoid the liver and you avoid the blood clots. And definitely low energy will be affected by poor sleep, and that is helped by progesterone. So again, I don't think it necessarily needs to be compounded. And it sounds like with compounded, it's most likely topical. And so that's good for avoiding the blood clots.
Right. I think the thing about it is like both of you have mentioned, both doctors, is that it is a consultation, a shared consultation with you and your doctor, and then information that you grab. I mean, this is one of the reasons why I love Positive Health Solution, because it gives me additional information than what we already have at Pandia Health and its community. And so we, as good patients, we need to be educated. We need to go in with our questions written down, because as Dr. Yen said, brain fog is a true thing. So write it down, ask those questions, and don't feel like you need to make a decision right then and then. It's okay to ponder that thought before you go on anything else. Well, anything we would like to say before we thank our guests for taking the time to be with us?
I want to do a testimonial for Positive Health. I have used their text educational service, and it's very high quality educational material every week on a different topic. I did sign up for all the topics because all of them interested me. And so it's great. You've really made an amazing product, Dr. Edwards.
Oh, thank you so much for that. And I would, for just going back to the question about questions to ask your doctor, we do have a document that is a laundry list of questions to ask your doctor. So that is available as well. I want to thank Pandia Health for the opportunity to collaborate on this webinar. And I hope that people have become more aware and learned, and they take from this the bottom line. They have options, and they should seek help and not suffer. Life is way too short to suffer when there are solutions.
Absolutely. Absolutely. We need to take care of ourselves. We take care of everyone else, but we also have to pay attention to ourselves. All right, everyone. Thank you so much for your time. I appreciate that you spent some time with Pandia Health. We have the scan code there. It'll take you to the page, the collaboration with Pandia Health and Positive Health as well. you have any questions, drop us a line. Our email is info@pandiahealth.com. Know that we cannot respond to any medical questions unless you're a patient. Then you have that relationship there. Thank you again, everyone, and hopefully we'll see you in our next event. Have a great day. Thank you.
Thank you.
Thank you.